Can everyone else see them?
Yep.
Oh, I can't. What's wrong with my computer? How weird. Okay, I can't see them at all, which is really strange, but I'm going to open my own slides then, and we'll talk through them. Okay, so second slide, please. So the first thing to say is that, this is a picture of multiple MTC teams ready to receive what was about 4 casualties on a Sunday morning. And I think whether or not you consider yourself to be a trauma expert, I know there's a variety of people working for the various retrieval teams. Some of you might have done London HEMS. I might know some of you have worked in MTCs and do so currently, and some of you might have had very little experience of trauma. But I think the message is that whichever MTC you end up taking patients to in London, we're very happy to support you, help you along the way, provide meaningful feedback, and obviously, we totally appreciate that you're trying to help do the best for the patients. And certainly my experience of receiving patients from the Nectar team in particular is that the transfers and retrievals are of very high quality. So I think you've got good consultants running the service and providing your governance. So today, hopefully what I'm going to do is give you a bit of confidence in managing this group of patients. Next slide, please. So you've heard a bit about the background for the London Major Trauma System, and you understand that there's 4 MTCs with the hub and spoke method supporting the trauma units. London's Air Ambulance, or as I said, was known as London HEMS, primarily is there to do trauma, a primary trauma response at the scene of the incident. We do a few secondary transfers every year, very few, probably less than 5 actually, and often for burns patients where there's no burns bed available within London or within Essex, and we have to take them further afield. But even that is less frequent over the last few years. And that's in stark contrast to most retrieval teams where actually your expertise is in doing safe transfer. There's less of a trauma focus and much more of a sort of lean towards medical patients. Obviously different HEMS teams such as Kent, Surrey and Sussex, Essex and Herts, they would also do medical work as part of their primary response, and they would also take on some secondary retrievals as well. But I guess the patients we're talking about today really are the ones where they're being transferred to the MTC for an intervention, and usually that intervention is time critical. But again, that's not always the case, but most of the patients you would be bringing to us would be patients who are bleeding, who are coming for damage control surgery or interventional radiology, perhaps neurotrauma patients coming for decompression. Less commonly, but possible, are patients with vascular limb injuries, and that's quite topical for us, not because of retrieval teams' involvement, but we've had multiple SIs recently where trauma units have struggled to recognise these injuries as being limb critical, if you like. And it's perfectly conceivable that if you had a multiply injured patient, this might be the reason for them to be transferred in a time critical manner. The other group of patients that get moved into the MTC are spinal cord injuries, and obviously they need the expertise of the MTC, but they're less time critical mostly than the other 3 categories that I've mentioned. Next slide, please. So it's quite important, I think, to think about when things go wrong, and you may all have your own cases where you think things weren't quite as good as they could have been, but we've certainly seen some examples, again, not with retrieval teams, but actually where hospitals have had to provide their own escort to bring patients to the MTC, or actually the wrong escort has been sent, and that's usually down to the skill set or experience of the individual. And I think it's important to recognise that actually having the retrieval system means that hopefully we're allowing hospitals to maintain their own staff and keep their own services going by adding in the retrieval team as an extra layer. And that also gets over the problem of sending perhaps a doctor who's available but inexperienced, or sending a nurse with a patient where they don't really have the skill set to manage the patient if something goes wrong. And sometimes that's related to an inadequate assessment or lack of treatment, which means there's more of a risk to the patient en route, and also risk to the member of staff who's not able to manage if the patient deteriorates. The other things we've seen go wrong are errors in communication with the MTC, and whether that's about the injuries that are sustained, it's about whether drugs have been given, what the next planned steps are, or even the ETA. And probably the most significant problem we've had recently is patients who are meant to come to the Royal London have been sent to the Royal Free. Now that sounds pretty simple and a straightforward error to make, but obviously it's critical because the Royal Free do not have the right facilities. So I think it's just worth reflecting on checking simple details like which hospital you're going to, or at least understanding the setup of the trauma system and questioning when someone says they're going to the Royal Free, or when the ambulance driver says we're going to the Royal Free, aren't we? And actually recognising that is wrong. So there's obviously lots of potential steps where we can make an error. And I just want to talk about the HEMS team for a little bit. Most of you will have worked with the HEMS team at some point, whether it's receiving patients. Some of you may have been out on observer shifts, but obviously it's a doctor paramedic model. We don't have nurses on the team. That's a historical thing, and really because we rely on the paramedics to sort of protect us, look after us and stop us getting injured in the pre-hospital environment. But that team works very well for us. I know that you have nurses working alongside your doctors, and that's pretty classic retrieval team sort of confirmation. Next slide, please. But what have the HEMS team got? So the HEMS team become very good at appreciating mechanism of injury, looking for scene safety issues and mitigating any risk there. They're used to working in uncomfortable and awkward positions. Good at doing a top-to-toe rapid assessment, and that's really a primary and secondary survey in one go, so that we can evaluate the injuries in one swift examination and then decide on the treatment priorities. That then allows us to delegate tasks using the team available, who are usually people that we don't know, but we have to try and delegate them skills and tasks that they're able to do. And our aim is to try and execute tasks perfectly first time, so what we call doing the basics well. We don't want to have to put a splint on and then adjust it 3 times. We want to make sure it's on properly the first time, so paying attention to detail. But the key things probably that the HEMS team bring are speed, pace and drive, and actually encouraging the other members of the team who perhaps don't have as much clinical knowledge or as many procedural skills, but trying to get them to work with us so that actually we can shorten on scene time and get those time critical patients into hospital. And then once we get to the MTC, we'll provide a handover which should be succinct and effective. So I'm explaining what the HEMS team do because I think in order for you to move these patients from a TU to an MTC, you really have to start behaving like a HEMS team, perhaps rather than a retrieval team. So one of the very important things about HEMS, though, is that we are consistent in what we do. A bit like you, we have standard operating procedures, but we're very consistent. So virtually any doctor could work with any paramedic and they would know exactly what to expect in a given situation. Now, obviously, when you're dealing with trauma, the amount of presenting complaints are relatively limited, so it may be a bit easier to anticipate that than it is perhaps for medical conditions. But how the team works, how we perform, what we do in what order, even down to the checklists we use, it's all very consistent. And I know there's some similarities in your retrieval teams. If you look at retrieval teams in general, though, the difference between a HEMS or a primary team is that you have a bit more time to think en route to the job, or certainly a bit more information usually. You've often got time to review the notes and the imaging. And HEMS teams have always had this debate in the past of whether you scoop and run or stay and play. And I guess for retrieval teams, a lot of the time it's a bit of tweaking and playing at the hospital before you move the patient. And importantly, adding layers of medicine and expertise, again, paying attention to detail and trying to finesse what's been done and improve upon it. So I don't want to offend anyone, but what I would say from my own experience of working in adult retrieval teams, there's often less pace and drive when you compare it to a HEMS team. And I think it's important to acknowledge that. And in some jobs, there isn't a need for you to go super fast, and actually going steady is the right thing to do. But I want you to try and take a little bit of what a HEMS team do for these type of patients. Next slide, please. Okay, so what you need to think about is focusing on the purpose and the target, and that will depend on the case, and it will probably depend on the advice you've been given by your consultant about the reason for you going and what they want you to do. But most of the patients, as we said, although there's not a specific list of the patients that you would attend, they're mostly going to be time critical. So it's worth thinking about where the delays occur, and obviously you're trying to avoid them. But what I'd recommend is that as soon as you get to the trauma unit, you start to quite aggressively push towards leaving the trauma unit and drive the team towards that end. It's very easy to get stuck in, and people start to give you more and more information, some of which is useful, but it's very easy to become distracted from the purpose, which is to get the patient out. Most of you will be familiar with the code red and code black pre-alert systems, which the HEMS or ambulance service teams can use to activate the MTC. The benefit of these is they're effectively care bundles which activate senior decision makers and proceduralists, so that when the patient does arrive at the MTC, we try and remove as many delays as possible and minimise risk to the patient. So when you're bringing a patient to us, as long as we know they're coming, we will activate the appropriate code and make sure the right people are there. But there's almost no point in us doing that if the patient is almost trapped in the trauma unit and everything is taking a long time in order for the patient to leave. So you have to be thinking about leaving the TU pretty early. Next slide, please. So from a communication point of view, it is important that you understand the usual pathway, and Professor Brose talked about it a bit. At the London, I don't know about King's, it has to be said, but at the London we use refer a patient as a written or an electronic way of knowing which patients are coming into the MTC, and there's a separate refer a patient module for the major trauma patients as opposed to orthopaedic or neurosurgical. But for the time critical patients, we ask the trauma units to make a phone call to activate us. They do then send an electronic refer a patient, but that comes after the phone call, and we would automatically accept anyone who needed to come to the MTC. And that's an ED to ED phone call as opposed to going through relevant specialties. And this phone number is the phone number that the ED consultant carries a DECT phone 24 hours a day. So that is a good number for you guys to have. If you have any problems, if you're en route, if you want to let us know something, that is the number to ring. So what we're trying to do is slot you into the system for major trauma. So making sure that the MTC know you're coming and giving us an ETA is important. And ideally, we like to have the blue call about 10 to 15 minutes before the patient arrives. And that gives all of the teams time to get in the lift, come down to resus, put their lead on, get a briefing on what we know about the patient and an anticipated plan, a plan A and a plan B. And when you place the blue call, if you can tell us about the injuries that you found and the treatment that's been given in brief detail but accurate detail, that's really helpful, and it saves us getting things ready which perhaps we don't need, such as chest drains. If they're already in, we don't need to get them ready as well. It's useful to get a timeline of events in your head, and sometimes you don't always know exactly what's happened to the patient, but trying to get the key times of the time of the injury, the time they arrived at the trauma unit, and the timeline of giving key drugs such as tranexamic acid and any other important timings are really important. From a handover point of view, you're then going to have to do a verbal handover to the trauma team and then provide us with documentation. Next slide, please. So from a practical aspect, when you turn up at the TU, you do need to examine the patient yourself. And although most people learn from ATLS to do a primary and then a secondary survey, the way we do it on HEMS is just to examine the patient from top to toe. It's effectively an ABC with a bit of D and E on the end of it. But you do need to know what injuries you think the patient's got in case something goes wrong during the transfer so that you can intervene. Hopefully the trauma unit will already have addressed any reversible causes of shock as far as possible. But remembering that if it's a bleeding patient, you're moving them to have damage control surgery, and you're not going to be able to correct everything to the extent that you might like. It's also really important to anticipate what might go wrong and have the kit to hand. And it may not be kit that you have in your pockets like the HEMS team do, such as thoracostomy kit, or a dish. I'm sure you have cannulas, but it's just worth thinking about what might happen and have you got the right kit out of the bag. It's also worth verbalising your what if plan with your retrieval team, with your nurse, or if you're the nurse with the doctor. And common things that might happen if your patient's not intubated: they might vomit, dropping blood pressure below your target, or actually seizing if they're a neurotrauma patient. But having the right jugs and a plan about whether you're actually going to log roll the patient if they're awake, what your blood pressure targets are and what blood products you're going to use. But again, don't try and correct everything before you leave the TU, because actually you're going to be using up valuable time, and that's why you're moving the patient, so that they can come and have definitive treatment at the MTC. Next slide, please. As far as packaging, my advice would be to secure everything, like not just the patient's life, but your life depends on it. If your ET tube falls out or gets pulled out, you'll be kicking yourself, and it might have been a difficult intubation. I know you know this from your normal retrieval work, but have a think about whether you're going to tape or tie the tube. I know that taping is, used to try and prevent the obstruction of venous return, especially in head injured patients. But actually, if your tapes don't stick properly, or the patient's got a wet face or is bleeding, a tie is often more secure for that transfer. And the way you tie your tubing is important. Some people just tie it in quite quickly, but when I was in Australia and we had to winch patients who were intubated, we were taught to tie it in a specific technique, which meant that if when we were winching the bag valve mask fell off and pulled on the tube would not come out, even if you dropped the bag valve mask while you're 100 foot off the ground. So worth thinking about basic skills like that. As far as lines are concerned, you obviously need to be accessible to the ports en route so you can give drugs or give blood products. And my advice is to secure all of your lines and your ventilation circuit and your monitoring. And we tend on HEMS to have all the leads coming over the right shoulder so that they come out of our packaging in one direction. And that works in any London ambulance and also on the helicopter. So if you brief your team that you want all the monitoring leads over the right shoulder at the start, it will try and keep them a bit neater, which makes all the ongoing transfers and movements much, much quicker. We also try and move the patient into a sort of single package, and we use blizzard blankets for critically injured patients, partly because they help with temperature control, but they also keep things neat and tidy and allow you to sort of wrap the patient up and have everything secure. And you can make holes in it for the lines to come out, but you can also tape your vent circuit right down the front and it will stick to the sort of metal foil. We often use a collar, and I know there's some debates about whether collars are useful or not pre-hospital, but actually they do provide some support for your ET tube as well, especially in kids. If their heads flex or extend, the tube is likely, it could potentially come above the cord. So we tend to use it, but we make sure that they're well fitting, they're not too tight, but they're sized properly and they're put on carefully by somebody who's making sure that you don't obstruct venous return. We also tend to use a scoop stretcher because it sort of folds the patient in on themselves and allows the patient to be a bit cocooned, and that allows a faster transfer when you get to the MTC. You don't have to delay to get a PAT slide, but the patient can just be lifted across, the scoop broken and then taken out, and the patient is lying on the recess trolley ready to be treated or transferred. Next slide, please. So if you think about the delays that can happen particularly at the trauma unit, it's usually related to people wanting to do extra imaging, put in extra lines, wait for CT reports, print out notes, get extra drugs or blood products, set up pumps, infusions, or find new batteries, or simply just look for the PAT slide. So you can anticipate all of these things, and some of the pre-arrival instructions that can be given to the TU, either by your retrieval consultant or by us as the MTC receiving consultant, we can try and help them prep for your arrival. So we can say, just put the patient onto a scoop stretcher, don't worry about doing the extra CT, we'll do it when they get here. Send the images on IEP, but try and print out any written reports. So you can try and get them to do those things before you actually arrive as the retrieval team, which will speed things up. But just beware of doing too much imaging or putting in extra lines, which you might like to have post-operatively, but actually they're not important for the transfer for the patient. You obviously need lines to administer blood products, but perhaps you don't need to have the art line that you would like to have. Maybe that can be deferred. Next slide, please. You obviously need to optimise your A, B and C, and I don't need to explain about obviously, checking your airway. From a ventilation point of view, you might be less familiar with thoracostomies. So we use these when the patient has got chest wall injury and we think they've got a pneumothorax or hemothorax. If they have a simple pneumothorax, we just do thoracostomies, and we very rarely put chest drains in pre-hospital. We do sometimes if they've got large volume hemothoraces, because it's useful to know how much blood is coming into the drain, because it may be an indication to proceed to a thoracostomy when we get to the hospital. But my advice would be, if you've got a patient who's had thoracostomies and the ventilation is adequate, you don't need to delay and put chest drains in. Chest drains actually cause quite a risk during transport because they can be falsely reassuring, but obviously they can kink or block. and then they need to be pulled out, or you need to troubleshoot them. Whereas if you've just got thoracostomies, you can just put a sterile glove on, finger the thoracostomies, release any tension if it's there, or just reassure yourself that the lungs are up. So sometimes keeping things simple is better than intervening, putting the chest drains in, which we know the patient will get, but they don't need to have them before they get to the MTC. Equally, if there are chest drains in, you may decide you want to take them out for the transfer, or you might decide just to check them and monitor them en route. From a circulation point of view, really important things, whether they're head injured or bleeding, is that they have tranexamic acid within 3 hours of the injury. The London Ambulance Service are good at giving the 1 gram, which is their protocol, and the HEMS teams now give 2 grams for bleeding patients. And at the Royal London, we give 2 grams instead of the crash protocol, which was a 1 gram bolus and a 1 gram infusion. So if you get to the patient, they're within 3 hours of injury and they haven't had TXA, you should be giving them 2 grams. And for the head injured patients, that's for patients with a GCS less than 12 or patients with blood in their head. And if you're moving them for neurotrauma, they will definitely have needed to have TXA. If you do need to give them blood products, you should be giving them in a 1-to-1 ratio. And it's most likely that you'll only have plasma and packed cells at that point. You might have platelets to give the patient. And if you do, you're lucky, but give them in a 1-to-1 ratio. And give them via a mobile warmer. I don't know what you carry, but if you can give warm blood products, that's much better. From a wound management point of view, you don't want any uncontrolled, non-compressible hemorrhage. So wounds should be quickly sutured or have good compression bandaging, or you may have to apply cap tourniquet if you've got arterial bleeding, which isn't controlled with compression bandaging. If you're using simple splints, such as a pelvic splint or Kendrick traction device, people put these on, but sometimes don't check that they're actually applied properly. And if they're not applied properly, not only do they not have a good effect, but they can actually cause harm. So checking, for example, with traction devices, that groin straps are not across testicles, that pelvic binders are in the right position, they're under tension, and for the Kendricks, they're under traction. So check all the splints as you would want them to be if you put them on yourself. And that's all part of your hemorrhage control sort of drill. For the neurotrauma patients, we talk about doing head up. The reality in transfer is that it is almost impossible to get a patient at 30 degrees head up. You would have to have their head sort of a metre above the ambulance trolley. But you can do best efforts at that, meaning that when you move the patient, you make sure they never go head down. If you're lifting a scoop, you make sure you've got strong people at the top end of the scoop to lift it up. And you can, even if they're on a scoop, you can lift the head of the ambulance trolley to lift them a little bit, but it is quite hard to do effectively. We talked about the carefully fitted collar, obviously optimising their ventilation, and that includes excluding tension pneumothoraces and equally putting an orogastric down if you think their abdomen's distended, if they've had bag valve mask ventilation, and that will optimise their ICP. Obviously sedation paralysis, and if you think if they have 1 or 2 dilated pupils and they haven't already had hypertonic saline, giving them 6 mils per kilo of 5% hypertonic saline as a one-off dose at the right time. So do that after they're ventilated and their CO2 has been optimised. So choosing the timing for that is important because you can't really repeat that dose. From an exposure point of view, it's very hard to increase patients' temperature when you're actually doing the transfer. So just try and maintain the temperature they've got. And again, whether you use blankets or a blizzard blanket and giving warm blood products, that will all help to stop further reduction in their temperature. Next slide, please. From an imaging point of view, if they haven't had their imaging when you arrive, don't wait for any more imaging unless it's absolutely critical. And I can't really think of an example when it's going to be, because you can use a clinical judgment, you can check your tube clinically, and you can make an assessment of whether splints are on properly. And most of the time, as I said, you're moving the patient to have an intervention. When you get to the MTC, we can do rapid plain films, ultrasound, or repeat the CT, and it's much easier to arrange that in most MTCs than it is in a TU. And particularly out of hours, trauma units still struggle, despite best efforts, to get imaging out of hours. And it's worth remembering the imaging is on the wrong system in most cases. There's a few hospitals in each network where the MTC can automatically see the images, but they may not be as good as the images would be if you had them at the MTC. So if it's going to cause a delay, just cut your losses and get the patient to the MTC. And again, it's worth remembering that HEMS don't do imaging to make diagnoses and work out what to do with the patients. Next slide, please. So from a documentation point of view, and this is really about North East London and Essex, the Royal London, Newham and Whips can all view each other's notes on COS and we can see the imaging, but we do need to have some paper notes or have the images sent on IEP to be able to view any other trauma unit. So if you can bring any paperwork and obviously fill in your own transfer paperwork accurately, that's helpful. And again, timings, drugs and CT reports are useful information for us. Next slide, please. So en route, once you actually manage to leave the trauma unit, you obviously need you'll have them on a monitor. A note about pupils, I think because you're retrieval experts, you often tape the eyelids shut, which is good practice, but it's really important to check their pupils often if they're neurotrauma patients. If they haven't already blown a pupil, you might miss that opportunity to give the hypertonic saline at the best time. So just make sure that someone's allocated to keep checking the pupils every sort of 5 or 10 minutes or so. En route is hopefully your time to be able to prep your notes and think about your handover. And it's worth just anticipating that most MTCs have pretty busy resus rooms. So just checking that your sedation is adequate, that you've given another dose of muscle relaxant before you actually get out of the ambulance will mean that your handover is smooth. You're not worrying about, oh, they need topping up or they need another dose of rock, but it's done. And then you've probably got half an hour for the team to get to grips with what's going on without having to give those drugs again. So just get yourself organised, make sure your kit is ready to offload the ambulance. So your vent, your monitor and your pumps, if you've got pumps. And I guess the other thing to say is you don't necessarily need patients to be on infusions. For the amount of time you're going to be in the back of the ambulance moving the patient, you can probably manage with bolus doses to keep patients asleep. And be ready to get out when the ambulance stops at the MTC. So have whether you have sort of aid memoir for your handover, have your notes and just be ready to get out quickly. You don't want to take too long doing that. Next slide, please. So this is a picture of the resus room at the London, and this isn't too bad. There's quite a few people here. This was a code red, but it can be worse than that. So I think if you're on a retrieval team and you haven't worked in an MTC, sometimes it can be quite daunting. We will do our best to welcome you, and the team leader should make it very clear who they are. And often there's a lot of senior people around, so it's important that you ask if it's not clear who's the team leader. But they should make you welcome and help you get the patient across. Next slide, please. So if your patient's got immediate needs, it's really important you tell us that as you come in. For example, if you've run out of blood and you think they need more blood, tell us before we even move the patient and we'll get that ready. We usually move the patient across to the resus trolley before the handover, because if we do want to intervene, the resus trolley is what we're used to moving, and it's a little bit wider than the ambulance service trolleys, etc. So we don't normally take patients straight up to theatre, and at the Royal London we don't take them straight to scan from the ambulance trolley. When you're about to hand over, if you stand just to the left of the team leader, that's a good position. Ideally, don't stand at the foot of the patient, because that's where the team leader wants to be, because the team leader will be doing their own sort of primary survey by looking at the patient, looking at their ventilation, looking at the monitor, and that's where they're going to stay afterwards when you leave. So if you stand to the left, everyone can see you and you're sort of in the circle ready to hand over. So hopefully you've got a structured way of handing over, and on HEMS we have a little list of things that we give, and we can share that with you if you want it. Ben Singer or Mamoon could give you a copy of that, and it just helps to have a structure, and it allows you to deliver a succinct but informative handover. And just take it from the beginning. Wait for the team leader to give you a signal that you're good to go, and that will usually be after the anaesthetist says yes, the tube's secure, I'm happy for handover. Take a big deep breath and then speak loudly and clearly so that everyone can hear you. You want to make sure that the whole team understands what has happened to the patient, what's been done and what needs to happen next. And just remember that someone's recording it, so try not to go too fast. You have to do it with pace, but don't gabble too quickly so that no one can understand what you've got to say, because you've got important information. Next slide, please. For your documentation, it's tempting just to stay in resus and try and write it sort of leaning on a corner of a desk, but my advice would be go somewhere nearby but quiet, where you can write good notes, and then you can come back and check if the team leader's got any questions. Find some water, get your kit back together, and then if you need any replacement drugs or kit, don't be afraid to ask. We can give you stuff so that you don't feel that your whole pack has been demolished on the way into the hospital. Next slide. There's some opportunities where if you would like to see what the HEMS team do, and I think it's really valuable, because if you're not sort of particularly into trauma, what I think most people learn from watching the HEMS team is that obviously we have an expertise in picking up traumatic injuries quite quickly, we hope, but also managing the team who you don't know, and that's very similar to going into a trauma unit where you're not known. And getting people to work with you quite quickly. So if you'd like to come on an observer shift, we can arrange that for you. The other things, if you haven't worked in an MTC much, we can arrange for you to shadow the team leader. And then also there's obviously education opportunities with the trauma M&M or governance meetings, and then trauma talks at Thursday lunchtimes. And then finally, next slide please, the take-home messages I guess would be that when you're doing these sort of jobs, it's a bit like doing a HEMS job in a hospital. So think of it as a rescue mission. Try and generate pace and get things right first time and do the basics well. Do as much as is needed for the patient, but as little as possible, and do it fast, and get organised for your handover at the MTC. And I think if you wanted to have a ballpark sort of target in your head, you probably shouldn't be taking longer in the TU than you think it would take HEMS to be on scene and bring the patient primarily into the MTC. So for an isolated head injury that has an RSI, we do it in about 20 minutes. And for a patient who's bleeding, who needs a few more interventions, including anaesthetic, probably half an hour. If it's purely a penetrating trauma patient, we'd aim to be under 10 minutes. So it's quite a big ask when you're not trained to do that. But actually, if you have that as a target, you're more likely to make it. So I hope that's given you a bit of an overview, final slide please, about what perhaps we might expect and what you might expect when you walk into a TU, and how you can mitigate some of the delays. And I'm really sorry about my AV IT issues, and I hope we've still got some time for a bit of a discussion and some questions. So thank you.
Thanks very much to both. That was wonderful. We've got from our side in the programme, we've got plenty of time because we can move back our next case and shift copy and things. So as long as you guys are good for a few extra minutes, that'd be wonderful. I recognise quite a few of those things, especially I think we're quite lucky in Nectar that a lot of our founding consultants are kind of still involved in London Air Ambulance or have been. I recognise from John McKenna kind of speaking to me about drive and pace and moving things forward. I think I'll start by handing to John just in the room and just see if we've got any questions from there, and otherwise we can move to the chat.
Yeah, that's great. Thanks, and thank you again to both the speakers. It's been excellent so far. A couple of questions from the people in the room so far, including me. How do you train or develop pace or drive or momentum, especially in TUs where, and this is a recurring problem sometimes, where it's not clear who has primacy over the patient, because it's not what we do day in, day out.
Yeah, well, I think the first thing is recognising that the patient needs you to change your gear. So recognising the need to have pace. And then I think simulation and training is actually really important. And you have to find, your own form of words to get people to move faster. You have to work out how to explain that the patient is time critical. And that's probably easier in a hospital, to be honest, than it is explaining to perhaps fire crew or police. But you have to just try and find a way of words, and also think you find your body language, how you move, how you respond. Actually, people will follow you if you're of the right demeanour. And I guess if you're a very outwardly calm person, you have to find a way of behaving differently so that people know something's different. We've got to go fast today. And perhaps the opposite, if you're a very, out there type stressy person, you probably need to find a way to moderate that a bit to get your team to go fast enough, but not dangerously fast and make mistakes. But I think simulation, talking about it, watching other people's behaviour, seeing good role models, seeing what does and doesn't work is important.
That's great, thank you. And we've got our own bespoke mannequin coming soon, and one of these sort of drills already on the list is the CRM aspects of speeding up a slow TU transfer. We've got another question from someone in the room. Jig asks, who should be moving the time critical patients within Northeast London or Southeast London? For example, the Code Blacks. Is it the local teams, by which we mean ED with LAS, and a frontline vehicle on an ad hoc basis, which may have inadvertent delays or problems with expertise, or should Nectar really be taking these on by default as a definitive role?
Karen, do you want to take that?
So I don't think there's an answer to it because it's not been defined or discussed. I think that's the kind of thing, and it probably is a discussion that should be had. These patients don't come along very often, but when they do, something needs to happen. You know, and it is very ad hoc at the moment about who's available and who's making the phone calls and things. So I think it would be good to have that discussion.
Peter.
I should shout into it.
You can shout into it.
So, given the fact that to get to the patient might extinguish the time required, or the on-scene time, as you've described it, is there a role for a co-located retrieval coordinator in Waterloo Ambulance Station so that jobs can be passed between the two in a timely fashion to avoid any unnecessary delays? We could have a pro-con debate, but because I know some people would disagree with that, but it strikes me that if we're moving down this level, this time critical, whether it's trauma or stroke, the sooner we know about the jobs, the better. And clearly, the way the trauma system works is you've got somebody sat in Waterloo who's screening and triaging the jobs, and our system at the moment may not afford the time that it's, you know, the timeliness to get to the patient, do those interventions in the time frame that's really going to benefit them, and that will then fall back potentially on the local teams who may not be able to do it as well in terms of the specifics of the retrieval. I'll stop, but that's my question.
Yeah, Pete, it's a good question. I guess I would think that actually the HEMS paramedic who's in the control room is already in a good position to do that, because they're often aware of if HEMS are, you know, not available for a job or missed a job, or as Karen said, you know, sometimes parents or a friend has taken a child or an injured person directly to a TU. So they're in a position where they could be that coordinator. I mean, you could employ another person, but I think, you know, there are ways that the TUs could either speak to ambulance control, because they usually request the transfer anyway. But you're right, that would be the place for them to get that information. Whether or not you use a different person, you would be better placed to decide. But I think a lot of the time we know those patients are in those hospitals, and getting that earlier call into you would make a difference.
That's it from the room at the moment.
LAS have a very strong coordination desk now, and it would make sense just to, you know, make sure that, you know, whoever, again, I think it needs to have a decision about who should be doing these and who's available to do these, but you know, then that information needs to be coordinated properly centrally. Obviously.
Thanks both. That's it from the room at the moment. I'm just going to pass back to James for the online questions.
So we had a question from Nick Haslam, just quite specifically, but saying patients requiring secondary transfer from trauma units with the change in triage criteria. You said it was a small increase of secondary transfers, but is it a specific group that you're seeing this in?
We don't know is the answer. We're doing that, or about to start that piece of work. Anecdotally, I would say it's pretty much the same people that we were transferring before. You know, it's elderly people who have normal GCSs who turn out to have something on their CT scan, people who turn, you know, they've been in some sporting injury or something, or low energy injury, but turn out to have a, you know, a spleen or liver injury that's got something on their CT that might need embolizing. You know, what we haven't seen is, you know, big time critical cases being missed and needing to go quickly down.
And suppose following on from that, then, in that group, do you think using a specialist secondary retrieval team adds enough value in those circumstances, or do you think, I suppose it's case to case and relatively heterogeneous, but do you think those patients are normally okay going via kind of LAS with the team? Or I know Mamoon's going to say that we add value to all transfers, so should probably do most of them. I see he's got his hand up, but what do you think?
I mean, not being part of either service, you know, it's probably not necessarily for me to comment. What I would say is that most of them are not critical care transfers. They're just transfers of essentially patients requiring ward-based care who need some sort of additional information. It would seem to me that it would be something that would be beyond, you know, be well below the skill set and expertise that you deliver, and B, you know, probably there would be more of them than you would want to handle and would leave you not on standby for the jobs that you do need to be available for. You know, I think there will be, you know, the occasional case who's on ICU at a trauma unit who will need a less time critical transfer, you know, who may be on ICU and have a pelvic injury that needs to come down or a spine that needs fixing, you know, and that would be a different case than Anne has been talking about, for example.
Cool. Passing to Mahmood.
Yeah, thank you both. Thank you both for coming, and apologies for being in and out. I had to step in to cover a rota gap in the London. I would caveat the statement you made, James. I think the ones who I completely agree with everything that Prof said. I would say, while we may be able to add value in those or on organ support, but provided we're able to do so without delaying access to definitive care. And I think that's absolutely vital. Like, we're only able to add value if we're able to add value to not just some fine tuning of some abstract physiological sort of variable here or there, but rather to the whole process, including a more efficient, expedient, and better handover to definitive care. And I think an important element of that is making sure that we stay well away from the jobs where we are not adding anything at all, such as those are ward-to-ward transfers. So we have to be selective to be able to offer a high-quality service. We have to have a framework for delivery, SOP for this type of move to be able to do so. And then we need to train and rehearse on it and govern what we do. So maybe 6 to 12 months down the line, we will be able to sort of upskill the quality of those, such as may well have been achieved in some subsets, like the burns one, where it is very protocolized the way it's being done by us now, and rightly so. That's been applauded and recognized. That's all I have to say. But thanks everyone for being here.
I mean, I suppose one group of patients where there might be an added value is the patient with multiple rib fractures who's decompensating at a trauma unit, either acutely in the ED or on the ward, where you know, there may be things that you can provide in terms of both respiratory and analgesic, or even local anaesthetic quick local anaesthetic technique support as part of a package of extracting them and bringing them down. It would probably need quite a bit of work in terms of understanding that capability and who would benefit and embedding it within the system, but it might be a group where, you know, they're teetering on a move to critical care anyway, they're coming down for assessment, and, you know, some early assessment and intervention, which is not the rapid extraction that Anna's talked about, but, you know, would smooth the critical care path into the hospital, which may well end up on respiratory support, you know, or you might be able to avoid them needing respiratory support by that earlier intervention. You know, might be an area to explore.
And John, any questions in the room?
That's it from us at the moment.
So it's just what, so as we've got you both here, we're junior in, you know, Nectar's been going kind of over a year now, Sprint's been going a bit longer, and these services have kind of come out of COVID, and that's where the funding and the money's come from, despite the need definitely being there. So we're very early on in our journey, and the London trauma system has been going kind of over 10 years. London Air Ambulance has been going since the late 80s. If you were back in the first few years of your services being set up or in the London trauma system, and you can look now 30 years down the line or 10 years down the line, you know, what would you tell your service and your service development, and what can we, you know, learn at this point? And, you know, I know it's probably a bit unfair because we've stolen a lot of the very good things that you do, and, you know, borrowed a lot of your consultants in the development of our service, but what can we take?
Oh gosh.
Well, I would say the most important thing is to collect data, and really good data longitudinally over these cases, because it's data that's going to support the continuity of your service with commissioners. And so high quality, robust data, the tendency is for M&M reviews to be longitudinal and case based, and you have to collect horizontal data, not just on what you've done, but also on the severity of illness of your patients and their outcomes. And you need to have somebody following up on outcomes as part of that data. The other thing, if you can do it, is to collect some patient experience data around, what did the patients think of your service, and possibly, other end users like the hospital that you came into and the hospital that you delivered to, in terms of, what the value add was for the local hospital that you retrieved from, in terms of having you there, what was the value of the system, because again, those patient experience especially, but user experience and things like quality and efficiency are all things that are very important. And then the other thing in today's world is, how did you tie the system together? Are you an outlier in the system, or are you deeply integrated within the system and part of how the system functions, which relates to things like Pete was talking about, in terms of how are you tasked and where are you based and things. So are you an outlier, or are you deeply integrated into the system? But all those things secure your commissioning in the future, I think.
Yeah, I think that's all very good advice, and I think you've already alluded to the fact that you've got consultants in the service who've got experience, and obviously Sprint have got the same. Whether it's KSS, London HEMS, you've got people who cover a breadth of sort of specialty and background. And I guess the things that have made London HEMS or London's Air Ambulance strong over the years are recruiting the right people who've got ambition. And then also just doing the important stuff, which is days like today. Clinical Governance Day has been a thing for London HEMS for 28 years or something, and just taking the time and investing in your staff to do the education and training, the governance, and that ultimately will pay off with people doing the job well, and your reputation is what will keep you going, and along with your data. So I think you've got all the ingredients, and from what I've heard, and the other thing I guess London HEMS does really well is we debrief to within an inch of our lives, constantly trying to improve, and that's how you get the marginal gain, saving time. You look at your times, you say it was 10 minutes too long, but actually you can never swipe a whole 10 minutes off a job. You have to find the 2 minutes here, the 30 seconds there, and just add them all up, and they can't become cumulative, and that comes with practice. And if you haven't got the volume of patients to practice on, we're lucky with HEMS in London, we have plenty of trauma patients to practice on, but if you don't have that, you have to do sim, and that's what you guys can do. And then when you do get a case, really break it down and aggressively scrutinize it.
Thanks very much. That was really brilliant, really enjoyable and informative. Really look forward to hopefully working very closely between our services, as we've kind of been doing so far, mainly in the background, stealing from you, but hopefully we can come see some more stuff. And what I really liked that you kind of both highlighted, and what I'm passionate about in Nectar, is just the equity of access. And I think that's what our service is founded on. So I'm really glad that you both talked about that, because it's something that's so important to us, that we're providing that equitable service to all our patients across, and really bringing that quality to them. So thanks so much. And I think we're going to move on now to Chris Ribbett, one of our registrars, presenting a longitudinal audit case. Thank you.
Thanks, James. Thanks, everyone. And thanks for doing my slides.
Yeah.
Hi, can everyone hear me all right?
Yep, can hear you, Chris.
Great, let's see if I can get my IT to work. Can everyone see my slides?
Yes.
Fantastic. So as James said, I'm Chris. I'm one of the Nectar registrars, one of the CT3 anaesthetic trainees. And this is a case from November. So I actually wasn't on shift for Nectar that day. There was no Nectar registrar on shift. I happened to be covering the A side of the Royal London ACCU, and the patient in question happened to be on the B side. So actually I didn't know very much about the patient up until the point that I was asked to do the transfer. The ODP on shift was Ben Roberts, and I can't unfortunately remember who the crew was. So as per our normal format, I do not know whether any of the sign-in and checks were done, but I believe as Ben was on shift, they probably were. And as for tasking communication, I have limited information, but I can tell you all about the patient. So patient transfer details is it was a Royal London to a Royal Barts transfer for
Chris,
cardiogenic.
can I interrupt you 1 sec? I think you're sharing your you're not sharing the actual presentation. Yeah, there you go.
Is that now sharing now?
We're only seeing like the editing view.
I just press play, but clearly doesn't want to work. Do you want to do it, John? Because you're probably more au fait with
Well, you can just flip through these. We can see them fine.
Yeah, see that all right?
Yeah.
Fine. So I can tell you about the patient. So at the pre-transfer, it was told to me as a Royal London to Royal Barts transfer for cardiogenic shock secondary to direct cardiac trauma. And my handover was as a 24-year-old gentleman who was admitted overnight last night, who's now on 0.3 mics per kilo per minute of adrenaline, and that's escalating, and on max vaso. He had low cardiac output, but I can't remember the exact number on our random number generator that we have, which is the Edwards monitor, and he's for transfer for consideration of VA ECMO. So a little bit more about this patient. This patient was a 999 call at 10 to 1 on the 6th of the 11th, which is the same day that I was asked to see him. And he arrested at about 1:05. HEMS arrived at 1:10 with CPR in progress. They proceeded to a clamshell thoracotomy, where there was an evident right ventricular injury which was stapled, and direct aortic compression was achieved at 1:20, at which point he was transferred to Royal London A&E Resus, arriving 5 to 2, with ongoing direct aortic compression at that point. He'd had a balanced transfusion of 2 units with TXA, calcium, and adrenaline in titrated doses, and he was given a further 4 units in Resus. He went from Resus to theatre, where they explored his chest and the pericardium was left open. They only found some chest wall bleeding, which was stopped, but the right ventricular wound had been correctly managed, and at that point required no further intervention. He did have a post-operative cardiac arrest with 12 minutes of downtime, requiring 6 shocks, VF throughout, and 2 doses of adrenaline. And he then arrived on the Royal London ACCU just before 6 o'clock in the morning. He was noticed to have seizure activity, was loaded with Keppra, and given sedation increased in order to control that. Put on the Edwards, which showed low cardiac output, and his noradrenaline was started to maintain a cerebral perfusion pressure. He went to have a CT head, which showed some early hypoxic changes, but there was still a discussion with Barts about transferring him there, and the discussion led to him being agreed for transfer at about 8 o'clock in the evening. So, condition of the patient, having heard about him tangentially all day, he was, as I expected, in a bit of a heap, but needed to get from where he is to where he needed to go for further management. Royal London weren't actually ready, given that I'm one of the Nectar registrars. John was in direct contact with me, as I'd heard that he was likely to be transferred. So I actually knew about it before the bedside nurse. So I turned up and told them we need to get some stuff ready. And about 30 seconds later, Ben Roberts and the ambulance crew turned up with the trolley. So there was a little bit of over readiness from Nectar, but I think actually appropriately so. As you'll see later in our timings, it meant that we spent a little bit longer at the bed space than we would normally like, John being keen on timings, but I think that's just because we were quite so ready, and actually the Royal London wasn't. I had an excellent handover, partly because I've been stalking his notes, and I was given a direct consultant to myself handover about exactly what had happened. Transfer onto the trolley, no issues. He had 4 chest drains in, so that was a little bit of a challenge. Maybe with learning we've just learned, we could have considered whether we needed to continue to use those or whether we could just leave them as they were. And obviously his monitoring had to be adjusted because we don't have any cardiac output monitoring currently available on Nectar. So we disconnected that. He had somewhat stabilized in the intervening hour between referral and my arrival. So actually his NORAD was no longer directly escalating, but was at quite a high dose. As far as the journey, I connected an adrenaline line just in case we had any further hemodynamic instability, because given his cardiac output was low and he was quite adequately constricted last time we looked, I felt that that would be the most likely intervention required. Luckily, wasn't required. As for readiness of the receiving hospital, as per discussions and messages to myself, I was aware that the cardiology registrar for the HAC Centre and Ben Singer, who was the consultant on 6A at the time and one of our HEMS and Nectar consultants, were going to meet me in the Bart Square and perform a V-scan. At that point, there was no, we were also joined by, I unfortunately can't remember the cardiology consultant on call's name, and they decided that there was no direct intervention required in cath lab, so he was transferred to 6A directly, where he was handed over appropriately to a full team. So mobilization time, John, I don't know if it was less than 20 minutes, but I suspect it probably was. We spent just over an hour stabilizing the patient, but that's partly because I think we were quite so prompt. Actually, we had a very good team organizing everything that possibly needed to be organized, but we had to source some extra pumps because we were running on so many different infusions of sedation and paralysis and pressors and my extra adrenaline for safety. A very quick transfer to Bart's, thankfully, a good application of diesel by the ambulance crew, but done in a steady manner due to his ongoing hemodynamic instability and conversations with them about that. And a handover within 20 minutes to a fully prepared, fully staffed unit with multiple nurses ready to receive the patient. Total job time, I'm assuming, is therefore less than 3 hours as desired. So some case analysis. The first thing is, I don't think there were many issues with my documentation. This is the PRF of the patient. As you can see, a very brief transfer. I noticed now that I didn't document a post arrival ABG, but I do remember seeing those two and sending those photos across to John, which is an acceptable practice within Nectar, and appropriately handed over to the registrar, who was happy with the condition of the patient. This is the printout from the Tempus, which demonstrates that actually we were very challenged in trying to get a blood pressure reading from him throughout the whole time that he was on it. This is because he was so shut down, but actually we had an arterial line trace throughout, as documented there. And the blood pressure was well controlled. So positive issues about this case analysis. It was a critically unwell and unstable patient who was safely transferred by a team that was thrown together. And the Royal London ACCU bed space nurse also came along on the transfer, partly because she hadn't done many transfers, but also as an extra pair of hands in case we had any issues. Adverse events, so patient factors. I suppose the biggest question that this raised to me, and this was also discussed at the M&M with the Royal London, was this patient truly suitable for a CT3 to be doing the transfer versus a retrieval team from Bart's potentially coming out? Obviously, they aren't commissioned for retrieval for VA ECMO, and they do VV ECMO retrieval. So whether this is an edge case or whether this is something that needs to be further elucidated. And actually, the next question is the suitability of transfer for this patient at all. So this gentleman had quite a significant downtime with ongoing CPR at the point of arrival of HEMS, with ongoing direct aortic compression at the point of arrival to A&E, and further arrest during his damage control surgery, and early signs of seizure activity and early signs of hypoxia changes within 12 hours of injury. So the question is this gentleman who would be for referral for advanced extracorporeal life support, is he even suitable in the first place, given that he's likely to have a poor neurological outcome? And in fact, that is exactly what occurred. He ended up having a poor neurological outcome and was palliated 6 days later. Technical and equipment factors, I don't think we had any. Human factors, I mean, I think we had especially good teamwork, especially considering that I wasn't on shift. I happened to have done 2 or maybe only 1 previous shift with Ben on Nectar, but have worked with him in and around the Royal London. So that meant that the teamwork came together pretty easily. And obviously system organizational factors, there was no Nectar reg on shift, which ideally should be something that we should aim for, but obviously on that particular day, there was obviously no availability of staffing. One extra comment is the human factors. They'd had a particularly challenging previous transfer. I was speaking to Ben about this. Actually, after we finished this transfer and on creating this presentation, he was happy to conclude that it was just a particularly stressful one. Again, he hadn't had someone he'd worked with before. He transferred from a East London DGH to another East London DGH for decompression, and it had been much more complicated and challenging than he had recognised at the time. And with hindsight, he may have acted differently than what did, though that transfer was safe, and that was playing on Ben's mind throughout the transfer of this even more critically unwell patient. So some further case analysis. I've already alluded to the neuro findings of the fact that he was palliated with extremely severe hypoxic brain injury. He went to Barts. He was never put on VA ECMO. He improved with starting milrinone, but it did also demonstrate quite a significant left to right shunt with an assumed traumatic VSD, not for initial intervention. I don't know whether, had he had better neurological outcome, that would have been something that they wanted to look at further. But he was weaned off the milrinone before having the neurological findings as documented there, and palliated and passed away 6 days post-transfer. That also raises the question as to whether the initial management, starting with milrinone, for example, should have been or could have been started at the Royal London prior to transfer, or whether he actually required the transfer at all. Although being in a place of safety for starting a VA ECMO in a hurry is probably more sensible than leaving him in the Royal London until he's even more of a wreck than he currently was. So some patient factors: obvious hypotension, on quite a lot of noradrenaline, but a clinical transfer. So a decision was made that we obviously have to transfer this gentleman. He's in cardiogenic failure, cardiogenic shock secondary to probably direct trauma. And we obviously don't have any way of monitoring that in the back of an ambulance. So I'm unsure of exactly what our best practice guidelines were. As I said, I attached an adrenaline infusion just in case it was required, but never felt the need to use it as he actually remained stable throughout the transfer. Issues with monitoring, yes, again, hard to read non-invasive blood pressure, and maybe the need for a cardiac output monitor for these particular edge cases. So the final sort of bit of this is looking at the human factors. So good teamwork with minimum introductions. As I mentioned before, me and Ben have worked together in different roles, but that just made working together in this easy. Stressful shifts for both myself on ACCU. Working on A side is stressful, especially when you're a junior reg like myself. And as I alluded to on Nectar, that particular day had been particularly busy with some challenging transfers. But on the good side, we had good handovers. Everyone knew the plan throughout. One of my point of facts is to always verbalize a plan and a plan of action and a plan if we deteriorate, which is also part of Ben's. So that was good practice. And one extra thing that I hadn't really considered is, obviously I was on call for the Royal London, and we were at Barts and it was rush hour. So the ambulance called into base and actually blue lighted us back to the London as I was still in possession of one of the crash bleeps and covering that site. So I think that's particularly good thought by that crew. So summary learning points: it's a clinical transfer for a significantly unwell patient with traumatic cardiogenic shock. Would it be appropriate for this patient to have been retrieved rather than transferred by someone such as myself, especially as there was no other senior appropriate person to transfer on shift, and whether the initial interventions could have occurred at the Royal London rather than starting at Barts on arrival. And one other question that was actually put to me by James was, there's a shock call, which is a call for those cardiogenic shock patients at Barts, and I'm unaware as to whether this happened or not. So just a question for anyone that might know the answer to that, if this patient was indeed shock called. Any questions, anyone?
I think if we pass to Steve first, who's kindly moderating the case in Ben's absence, because I think he can fill in a few extra details about the case and answer that question.
Yeah, so I can. So thank you very much for presenting the case, Chris. It's really helpful, and I think it goes through actually a very complicated and slightly challenging scenario. So part of the reason to get him across quite so promptly was not actually for VA ECMO. It was a concern about a young person with cardiac shock in whom there was a suspicion, although not a great one, of a coronary injury. And so part of the reason that he was met by Prof. Mather and Ben that was actually, we thought he was likely to need an angiogram. The VSD was diagnosed later. So on review of his subsequent imaging, it was actually present. It just hadn't been demonstrated well. And to speak to your point about the shock call, so the shock call, so it's used where there are points of controversy. And so where there are concerns about whether a patient should or should not be transferred for or kind of receive extracorporeal support or transfer, we would use that to get an MDT opinion at that point. Where there is no controversy, so we don't need to activate that, if that makes sense. And certainly, as you speak to, there was a discussion with the ACCU consultant about timeframes and moving, and feeling that coming to get him at the time where we would have been able to would probably have taken longer than it would have taken you to get him across because of what else was happening at the time. So that was also an additional pressure at the BART site. We were running a number of pumps and having to change a circuit quite quickly at the same time. So that was part of the speak. I wonder if anyone has any comments about anything that Chris has presented. Or any questions in the room?
I've got a Nectar question, which kind of alludes to this case. What I know it's always ad hoc, and it's important that we run a team, and often we've all been working through COVID where there's short-term sickness and things change, and it's rapid changing things. So I've done shifts where I've been a doctor without a nurse, and we've taken a nursing colleague from another site to kind of backfill that gap. And I know that we've had shifts like this where we've had nursing staff. What's the standard? Was there an ask maybe given this patient's hemodynamics for the consultant to come for this one? I was going to say, it sounds like it was a very dynamic situation, and we were lucky Chris was there and John was attached, and John was in touch. I know John has used me at Bart's after a shift to move a patient in similar circumstances, and it's probably what's best for the patient at the time. But I'm just wondering if that was explored.
What I can tell you is that subsequent to this case and others, we have and John will back me up on this, I'm sure, and Mamoon, we don't let other people use our staff. So unless we can field a full team, then we don't kind of loan our ambulance or our kind of AHP or nursing support. We come as a package, and where this was a difficult time in terms of staffing, as John will no doubt allude to, we had challenges around this period. Yes. Should the consultant have come? I think it was discussed. The feeling was it was time critical, is my understanding. I wasn't the consultant of the day either for Nectar, but I think by the time said consultant had come, we may not have gotten the patient there as quickly. What interventions did they have? Well, again, speaking to the main concern, as I said, was one of a coronary injury. So I think inotropes and all of those things are great, but where you have an ischemic patient, the only thing that makes a difference is Revasc. And so that was where the drive for a kind of a time critical move would be, in the same way that we would with someone who had a STEMI or an out of hospital arrest where they've got ECG changes. We would consider that a rapid move. It's not ideal by any stretch of the imagination, and I think we all learned a few things from this case, and we have changed our practice subsequent to this case about what we would do.
If I can just jump in, I'm not going to repeat everything that Steve said, but everything he said is correct, as usual. So yeah, we did change our practice as a result of this. We no longer, as he says, we no longer run a team that doesn't include a Nectar doctor or consultant. As a result of not this job with Chris, thankfully, but the one before, where our ODP was put in quite a difficult position by a doctor he had never worked with quite a complex patient, and so that led to a direct change in our practice, which means that we will now no longer offer that service because it is simply not part of our spec. But thankfully, we're no longer in a position where we have to do that. We haven't had an absence on short notice quite in a long while, and this absence was a last sort of late night COVID positive pullout, which was quite difficult to cover, unfortunately. But now we've got everyone vaccinated and we've got a little bit more resilience in the system, thankfully.
Any questions in the room, or anyone want to put a hand up, or questions in the chat?
I want to know, actually, would anyone have done anything different from my perspective? Like, obviously, Steve, obviously, with the coronary injury being a potential issue, inotropy wouldn't necessarily have been the best thing to start off with. Obviously, that wasn't the case. But I attached my adrenaline lifeline as well as a drug giving line. I didn't start it. Would it have been prudent? Would anyone have done anything different? Was that overkill? Was I treating myself?
Well, I don't think it's overkill. I think this just speaks to the difficulties of managing cardiac shock when you're at the extremists of it. That actually, our pharmacotherapy, we know the more of it you need and the more numbers of drugs that you need, the worse your outcome. And we have even with all the bells and whistles that we have, the mortality from cardiac shock, leaving aside traumatic, it hasn't shifted much beyond 40 or 50% when you're in the kind of DE, so kind of the high end range of kind of badness. Even over the past decade, with all the intervention, it still remains a condition which has a very high mortality. I think that what we do know is that getting Revasc works. We know that inotropes can buy time, and we know that getting to a place that can offer more advanced therapies are the things that you can do. And I wouldn't have done anything different personally. I think adrenaline would be my first reach to if I was going to do a transfer like this. Drugs like Melbourne have a washing time of hours. So, and I would say that when he had inotropic therapy here, he did that against kind of a PA catheter and other kind of forms of advanced hemodynamic monitoring. So we didn't really know what the situation was, and it was very difficult to work out his hemodynamic status. Yes, we were worried about a low output state as being the main problem, but actually that's not always that easy to figure out, particularly when you've got holes in the heart.
Chris, I have a question for you actually, and this sort of dovetails off of what I was speaking about in terms of the ODP. So one of the areas of conflict that came up, as I understand it, was without getting too niche, there was some conflict over whether this nurse really needed to come, because the bedside nurse, and yes. That was not because she wasn't going to be incredibly useful, as all critical care nurses are on transfers, but it was more that the sending site was not happy for the patient to go without a nurse, bearing in mind that we still had an incredibly experienced ODP filling the role of our second seat. Can you speak about that a little bit? If there were some. So
I specifically spoke to Ben about this before putting together the presentation, because obviously I don't want to stand on his toes or speak with his voice. He didn't want me to include it because he felt it was a interpersonal difference between him and the specific nurse in charge. However, from my perspective, Ben in the back of an ambulance is as good as any, if not better than most. So I'm very happy to have Ben on that transfer. And any of the Nectar people that I've worked with would have been totally adequate and more than suffice. Obviously, more hands the merrier sometimes for some things, and there was a spare seat. Had we had the necessity of an escort or whatever else, then I would have chosen Ben over the ITU nurse if I had to make a choice. Yeah, I don't have much to say other than more than happy with Ben's support. Sort of semi-related to that is more of a comment that as Nectar develops and grows and we offer our teaching and our shifts and our opportunities to people within the region, trainees, both nurses, ODPs, registrars, doctors, paramedics, it allows us to have this opportunistic pool of people who are more well versed in preparing a patient for transfer, being aware of what the requirements are for Nectar referral. I know I'm keeping tabs of which Nectar registrar has made the most referrals to Nectar himself, and that's James Wading. And when he gets to 10, I'm going to buy him a T-shirt. But it is quite a useful network to have, I think. But it does mean that occasionally put you in this difficult position. Well, I assume it was difficult, saying, "Hey, you're on call. You're on long day on 4F.
you want to hop in an ambulance and do a transfer for Nectar sort of ad hoc. How did that make you feel?
I mean, honestly, the reason I chose to do any Nectar locums in the first place was to be able to be the person that can jump in the back of an ambulance at 2 o'clock in the morning and be totally comfortable with that, or not totally uncomfortable with that. That's the reason I did the first set that I did. I enjoy them, that's why I continue to do them, and it's a good skill to maintain. So long as it leaves adequate staffing where you're leaving, personally, I don't have an issue with jumping in an ambulance for the benefit of the patient, if that's what's really necessary, given that that's the reason that I chose to do it in the first place.
Thank you.
Nick, in answer to your question in the chat, I can't remember who the Nectar consultant on shift was, but I had lots of information from John, and Pablo was the consultant on the B side, and he gave me lots of information, and Ben was involved as well. So I don't know who. I'm sure I was told, but I didn't get much information from the Nectar consultant, but it wasn't actually necessary given that I was quite involved in the case from working alongside it. And I think actually, now that Steve's reminded me about the fact it was for Revasc, I did actually know that at the time.
Comments from anyone else? First thing I'll say, I think that's pretty.
James, you're really breaking up on my end.
Hear me, or
You're breaking up, James. I'll take over if that's okay. Yeah, thanks very much, Chris. Really appreciate that. I mean, it's a unique case and does demonstrate some of the more difficult elements of cardiogenic shock retrieval, which is something that we're actively working on at the moment between BARTS, the cardiogenic shock pathway, and Nectar, where we slot into that, and some of the more unique elements of the CRM, especially in a sort of surprise manner. So that's it for now at the moment. What I think we're going to do, if that's all right, is push on to coffee. We're just finalising whether or not Sprint are going to be able to speak this afternoon. It does look like probably not due to the clinical workload, but they have half an hour to see whether or not we can change that. After that, we'll follow on with a bit more of a decision-making talk and then some moderated discussion. James, did you have anything you wanted to add? I'm not sure if you're still breaking up the way you were.
Is that any better?
Way better.
Oh, sorry. I think it's my microphone. But I was going to make the same point as you, basically. It was in one of our first clinical governance that we spoke with Alistair Proudfoot about cardiogenic shock and the shock network. And I think that's something, as we build our substantive service and we train more, is something, a place where we can really add value. We have a wealth of cardiogenic shock experience within the consultants within the service and some of the registrars as well. And I was just wanting to say, I think I'm not sure if I broke up before this point, just really well done to Chris, because actually doing a challenging time critical job on the hoof when you're mentally programmed for something else that day, you know, being on ITU, you might be thinking, I've got a CT transfer in a bit, I'm going to have a coffee now, I'm going to do this, the ward round's done, to then suddenly being like, oh, I need to package this patient and move them time critically on a mic of NORAD to BARTS. It is pretty exceptional. And I think you did really well. And if Steve says that there's not much that you wouldn't have done anything differently, you know you've done well. And just a thought on I know Ben's not here to talk about things, but I think there should never be an issue about, I think we need to educate the people that we're receiving from and transferring to. We're providing an expert service that's appropriately qualified, that meets the requirements to transfer these patients. So that should never be a question or an issue, really, and something that we need to iron out, because there's no one that I'd rather do a transfer with than Ben Roberts, to be honest. So yeah, anyway, so thanks very much, everyone. I didn't mean to have a little monologue at the end there. As you said, we'll find out. So if Sprint can't present at past, will we maybe be presenting earlier, or will we have a longer break?
Yeah, we'll move everything forward if they can't make it.
Brilliant. So we'll see everyone at past. Thanks very much. See you soon.
Thank you.